Thanks, Jeff, and I'd like to welcome all of you this morning. To begin with, I just want to warn you that the slides I'm going to show you are not the same as what you have in the handout. Some of them will overlap, but I do want to point out the first slide that is in the handout, which I don't have here, and I think that really kind of summarizes the problem. And it's just a cartoon, and you see two dinosaurs kind of gazing out in the horizon, and they see Noah's Ark kind of drifting away. And one says to the other, crap, that was today. And that's supposed to be the first senior moment. But this is a problem this is the challenge that we're going to have, that is, and you're seeing it already, that people come in complaining of forgetfulness, and we have to decide, is that the start of Alzheimer's disease? Is it something else? And how are we going to go about doing that? Well, to begin with, following the principle of first things first, I think it's worth asking, what is the value of making an early diagnosis of Alzheimer's disease? Does it really matter if you make it now, early, or a year later, or 2 years later? And there's several potential values of making an early diagnosis I'll just mention. One is, of course, the person may not have Alzheimer's disease. So they may have something else that's reversible, though that's not very common. But what may be much more common is that you'll find some comorbidity. So they may be on drugs that impair cognition, or they may be depressed, and things that you can actually improve upon, and even though they may have an underlying disease, you can improve their function. We know that treatments can slow down functional decline. Dr. Winton will talk about that later. This opportunity to participate in research I don't think is unimportant. And there are studies that look at people who are in studies, and people who are in studies actually do better. And I think we're very fortunate here in this community to be able to offer those opportunities. So here at the Cleveland Clinic, we have a number of clinical trials going on, and really that's how we're going to learn things. And so we encourage people to participate and be participants in some of these studies that are looking at disease-modifying therapies. Probably another factor that we talk about, but I think don't really focus on quite as much, is this idea of capacity to decide one's fate. It's certainly earlier in the process that you address this with the patient, the better it is. And I think we should address it early. I don't think it's always done. But really have the person, the patient, the family, think about future planning early than later, and then having people scrounge around to do things. So for all these reasons, I think there's a lot of justification for making an early diagnosis of Alzheimer's disease. Having said that, then the question comes up, well, who should we evaluate? If you're in a busy practice and you're seeing people every 10 or 15 minutes, do you check everybody who's older, or are there certain people that you really want to focus on? And these are some of the factors that may help you decide who would be at the highest risk. So certainly people with risk factors, age being probably the most important. And just remember, the incidence and prevalence of Alzheimer's disease doubles every 5 years over the age of 60 or 65. So when you're between 60 or 65, the incidence or prevalence would be maybe 2 or 3%, 5%. But if you look at people who were over the age of 85, that may be greater than 50%. So it may not be worth your while spending a lot of time evaluating every 60-year-old that comes in who has no complaints, but you may have a very good yield at starting to evaluate everybody who's in their late 70s or 80s, because then you're more likely to pick up things. If they have other vascular risk factors, again, we'll hear about later. Certainly we presented some information last year looking at the relationship between increased peripheral vascular disease, increasing the trajectory to Alzheimer's disease, accelerating the trajectory. So we know vascular disease is a risk factor for Alzheimer's disease, and perhaps its trajectory. Head injury can be a risk factor as well. Many of you know that we're doing a study of professional fighters here in Nevada, really focused more on another condition, chronic traumatic encephalopathy, But there's no question, there's many studies suggesting repetitive head trauma is a risk factor for Alzheimer's disease. So looking at people, identifying potential risk factors and looking at that group, of course, would be important. People that come in with memory complaints. Now, it's a common thought that if somebody's complaining of memory problems, they can't really have Alzheimer's disease, because if you have Alzheimer's disease, you have no insight into the illness. And that's true of some people, but again, there's been studies of people who come in with just complaints of memory problems, and they test out normally on your screening test. But if you follow those people over time, a majority of them will progress. So these people really have insight or can see these very mild changes that are happening to them, and I think we need to take those seriously. Certainly if they're brought in by a spouse, children, informant, that's a real clue to focus in. And we know that the informant questionnaires, for example, can be very useful diagnostically for early detection. And then those who come in actually with behavioral changes. So depression, anxiety, particularly if they've never had that throughout their life. And I just want to show this study. This is kind of a classic, and it just looks at the timeline of behaviors in Alzheimer's disease. So 0 being the time that they were diagnosed. But if you focus more on the left side of the screen, you can see that many behavioral symptoms, apathy, loss of interest, depressive symptoms, irritability, can occur many years before the diagnosis is made. So even people that come in with, again, depressive symptoms, or they're losing interest in things, even if memory isn't their major complaint, although it's usually there, those are people you need to at least think about the possibility that they may have a dementia such as, or a disease such as Alzheimer's disease. Now, the criteria for diagnosis of Alzheimer's disease is the same as probably what you've grown up with. It's been there the last 25 years. And it's summarized here. I think you could just think of it as having 3 major components. This is the clinical diagnosis that we commonly use. So you have to have a dementia. That is, you have to have memory impairment and impairment of some other cognitive domain that's severe enough that it's impairing your function. So you have to have that. The disease process or course of the disease has to be consistent with Alzheimer's disease, so that is gradual, progressive changes, with memory being an early feature generally, executive functioning being an early feature generally, in the absence of any marked physical changes early on. So you shouldn't have early incontinence, you shouldn't have early gait disorder, you shouldn't have early seizures. So you have those 2 components, and then you have to be sure nothing else that in and of itself can cause the same type of clinical picture. So that's the diagnostic process. Now, with that, you can see there's not that much you have to do, but you do have to do something. So getting a good history, and the critical part here is getting history from an informant. So it could be a spouse, it could be the children, because obviously the patient, even if they have some insight, may not be able to totally give you a good recall of the course of their symptoms. Reviewing their medications. In general, again, finding a reversible cause of dementia is not common, but of those reversible causes, drugs and depression are probably the most common. So looking at their medications, making sure they're not on anticholinergic drugs, making sure they're not on a bunch of benzodiazepines and narcotics and things that people get put on even in older ages. Family history may be important. That's genetics, of course, is the other major risk factor for Alzheimer's disease. Sometimes that's hard to call out. If a person's parents died relatively young, or they haven't really established what they had, if they had some cognitive changes. Neurological exam, mental status examination, some type of imaging of the brain, which preferably nowadays would be MRI scan, and preferably MRI with volumetric measures, which we'll talk about, and which is available here in the community. The basic laboratory test, the dementia battery, B12, thyroid, general chemistry, CBC, and so on. Neuropsychological assessment in some, Dr. Banks will talk about that. And then PET scanning when available, which of course it's available everywhere here in the city, PET scanning, and we'll talk about that. So as far as the cognitive testing, turns out that actually most clinicians don't do cognitive testing or mental status exam. It does take time, and people just don't do it. Most clinicians who do it don't usually use a formal test. And there are a bunch of tests, the standardized tests, and many of you are familiar with the mini mental state examination. 30-question test, very commonly used, can teach any staff members to do it. And then there's other ones, Montreal Cognitive Assessment, Mini-Cog, there's a bunch of other ones. In some sense, they all have limitations. So they all have a certain ceiling effect, a floor effect. Which one should you choose? I think it's important to choose one. Here, we choose to use the Montreal Cognitive Assessment Test. And this was chosen for a number of reasons. Remember, the mini mental state examination is heavily focused on orientation. Orientation questions, and then the other questions are really pretty easy. So they're naming a pin or a watch. And so you're not going to pick up people really early with that test. The Montreal Cognitive Assessment is a little tougher. So some of the things that it tests, like for memory, instead of three words, it's 5 words. Instead of naming 2 simple objects, it's 3 animals, one which is a little more uncommon. But it also has other features that tap things that the MMSE doesn't. So it taps executive functioning using a TRAILS test, which is or an abbreviated TRAILS test, which is on your left hand, where you just connect circles, alternating number and letter. There's clock drawing. So it just has a number of features. Doesn't take that much longer to do. Can, again, be taught to other people to administer, and is not copyrighted. So it is something you might want to think about, but whatever you use, it's worth using something. I think that's the message. Now, of course, there are challenges in diagnosis that we all face, and this is not news to you. So one is the difficulty in recognizing people early. So what are the barriers? Well, symptoms are subtle, just like in the cartoon. So if somebody comes in and they go up to upstairs to a room and they can't remember why they went in there, is that abnormal? Yeah, maybe. That may be the start of Alzheimer's disease. So those early symptoms are subtle and sometimes hard to distinguish from like what's normal aging. Social graces are often retained. So again, if you're spending 10 or 15 minutes with a patient, they're coming into your office and you have to go through their hypertension and diabetes and osteoporosis. And you're just talking to them, they may seem completely normal, particularly if their language function is good. Sometimes there's concerns about the stigma of the disease. So sometimes families don't want to recognize it or just try to slough it off. And then, this is medicine in 2012. I mean, there's just not a lot of time to see patients and spend the time that you need. And we understand that's a concern. What we really like is a definitive test. And as you'll hear as the day goes on, that may not be too far away, or at least tests that may be very helpful in diagnosis. Now, in terms of the diagnosis itself, there's different situations that also are challenging. So you have a young patient, somebody in their late 50s. That Alzheimer's disease occurs then, but it's not that common. So these people obviously need a real full court press in terms of the workup. There's atypical presentations of Alzheimer's disease. So for a good example would be posterior cortical atrophy. It's just a variant of Alzheimer's disease which begins more with visual disturbances or visual perception disturbances. So they don't always present with the classic, memory amnestic type syndrome. Some people have dual pathologies. So they may have, you get a scan of the brain, and it comes back and it says high signal lesions in the white matter consistent with microvascular disease. And is that a vascular dementia? Hard to know. Could they have Alzheimer's disease kind of in there as well? Sometimes that's difficult to determine. Although, again, there's some tests these days that may help you make that distinction. And then comorbidities. So You'll hear about the differential diagnosis of Alzheimer's disease, so I'm not going to talk about that much, but just to point out that you can have Alzheimer's disease and strokes. You can have Alzheimer's disease and Parkinson changes. So sometimes it's not always that clear. Now, there's been a recent clinical pathological study that was done, and this is from Alzheimer's centers. So, NIH-sponsored Alzheimer's centers. These are the people that spend their whole life just diagnosing Alzheimer's disease. And so they looked at the diagnosis in life. And these people had been followed by practitioners, so this is their diagnostic impression, and then what they had at autopsy. So this kind of tells us the performance of our clinical criteria in the best hands. So the sensitivity was about 80%. But you can see the specificity was 60%. These are again, the best people. What's also very interesting is those that were diagnosed as not having Alzheimer's disease, in 40% of the cases, they had Alzheimer's disease. So you can see that our criteria that we have now, although it's been useful for 25 years, still has some deficiencies, and we just have to recognize that. But I think the good news is we're now developing biomarkers and tests that, again, you'll hear more extensively about, that may help us get a little better with these numbers. I think in the biggest paradigm shift in my career in the field of Alzheimer's disease, 25 years, is this. And Dr. Cummings will talk more about this too. But most of the time in the past, we've been spending in this realm of dementia and understanding people who have dementia and understanding their clinical features and pathology and so on. But it's been more and more recognized that this is a disease process that goes over many, many years, decades. And Alzheimer's disease pathologically starts, of course, when you have no symptoms. And then that symptom profile is just a gradient. It just gets worse and worse and worse over time. So you can see if we're working in the dementia phase, that's fine, but that's near the end of the disease. And really where we want to be, particularly if we develop disease-modifying therapies, is more to the left. And again, you'll hear more about this, but this is, really where the field is moving. And we need to be prepared for that. So as disease-modifying therapies come available, which may not be that long, we need to be ready to diagnose people early. So this is some of the criteria. I'm not going to spend a lot of time because that's the topic of our next talk, of kind of pre-dementia diagnosis of Alzheimer's disease. But I will talk about some of the biomarkers because these are commercially available, have been actually, many of them for a while, and still can have a place in the diagnosis today. So we'll talk about a couple of these. One is volumetric MRI scan. Now we do that here at the Cleveland Clinic. So if you order a scan, if it comes here, you will get volumetric measures of the brain. And one of the features in Alzheimer's disease is hippocampal volume loss. So here you can see this very obviously. So on the left side you see a patient, normal patient, and the olive green kind of deep in the middle there, that's a hippocampus. Looks normal, that's normal size. And then you can see somebody with Alzheimer's disease where it's quite atrophic. Now this is something you can see just very obviously, but again with volumetric measures you can make more precise measures even that are harder to see visually. And we know it's coming from neuronal loss because of studies that have looked at imaging and then pathology. And there's a correlation between the MRI hippocampal volumes and the number of neurons in the hippocampus. So we know at least a component of it is the fact that cells are degenerating. PET scanning, of course, is readily available, as I mentioned. It is approved by Medicare. So Medicare will cover PET scanning for memory loss greater than 6 months in the United States. And there's a typical pattern that you see in Alzheimer's disease. So hypometabolism in the parietal regions posteriorly, you can see on the left side. And of course, it can be very useful in differential diagnosis. You can see here on the right side of the screen, a person with frontal temporal dementia. Picture looks totally different. Now again, there's always overlap and such, but PET imaging changes relatively early in the disease, I'll show you, and so it can be a very useful test, non-invasive test, to help make the diagnosis of Alzheimer's disease. What's coming up, or what's actually, again, soon to be commercially available, though hard to know how it's going to be covered by insurances, is PET amyloid imaging. And it's just what it describes. So now instead of injecting glucose that has a tracer, you inject an agent that binds to amyloid, and you can image. And this is a Pittsburgh compound B. So this is a compound that was used initially in the research. There's now another compound that the FDA has approved, but basically you can see the difference. So you can see the control on the left side of the screen where there's hardly any amyloid, and then a patient with Alzheimer's disease. So you can image amyloid actually in the brain very early. And then what's also commercially available is CSF studies that measure amyloid. So this has been available for a long time. So you can see the different profiles. In Alzheimer's disease, you see a decrease in CSF amyloid levels. You can also measure tau, the other protein that's involved in tangles, and that increases in Alzheimer's disease. And if you use the two together, it can be useful from a diagnostic standpoint. Now, does everybody need PET amyloid imaging or CSF studies? No. But certainly in cases, early onset cases that there's a question in differential diagnosis, these tests can be useful. Now, by the way, this is not covered by Medicare. So the CSF studies are not covered by Medicare. PET is. What's really interesting, if you look back just on the left side at the control group, so you can see where there's overlap. So there's some patients who are normal or may have mild symptoms, yet they're in an Alzheimer's range of their CSF. So what happens to them? Well, if you follow them, the problem is, if you follow people who have abnormal CSF, in this case, they did have mild cognitive impairment, so they have memory problems more than what you expect for their age, but they're functioning normally. So if you follow them over time, 5 years down the line, most of them have progressed to the diagnosis of dementia. So CSF amyloid levels may be useful in some sense as a predictive test. And so I think what these biomarkers do is just kind of summarize the pathology of the disease, which, again, not everybody agrees upon, but I think the common thought is this, that we all have an amyloid precursor protein in us, and it can be processed in many different ways. In one way it's processed by certain enzymes. You get these fragments of beta amyloid, and beta amyloid likes to aggregate. So first you get oligomers, little pieces of them together, and then they disrupt synaptic function, and then they cause other changes to occur. So you get tau aggregation, and you get inflammation, and you get all this other stuff that's happening that eventually leads to cell death. So if you look at kind of how these biomarkers evolve, it's what you'd expect. So probably the first changes that we could see from these biomarkers is changes in amyloid, so low CSF amyloid levels. We start seeing amyloid on PET amyloid imaging. Then you start seeing the synaptic changes through PET, FDG PET, so that's next. And then as cells start to degenerate, then you see the hippocampal volumetric loss. And then you see tau, which reacts, tau kind of, if cells are injured, tau is released. So as the cells degenerate, tau goes up. And then you start having symptoms. So you can see these biomarkers, and again, we'll hear more about this, but these can be actually useful for diagnosis now, and hopefully will be useful in identifying the disease earlier. So I want to finish up just by mentioning the last thing, which is genetics, because testing is available for that commercially. And just remember, in Alzheimer's disease, there's two ways genetics play a role. So there are families that carry mutations. So they have a mutation. If you inherit the mutation, you will get the disease, 100%. Now, the good news is there aren't that many families that have that. And usually these are young onset families, and you find it from generation to generation. But we do have a test that you can order for the most common mutation. It's not the only one, but perhaps the most common. That's this PS1. So that can be useful in patients with a strong family history at early age of onset. And the other thing about some of these people that carry the PS1 mutation is that their presentation isn't always classic Alzheimer's. They can have other features, actually more neurological features as well. But the more common situation is what we would call susceptibility genes. So that'd be a gene that's normally in the population, but may have several different forms. And ApoE4 is the one that's been tightly associated with Alzheimer's disease. It comes in 3 variants or forms, 2, 3, and 4. And ApoE4 is overrepresented in Alzheimer's disease. So if you have a progressive dementia and you carry E4, it's very likely the dementia is due to Alzheimer's disease. However, it is not a predictive test. So it's not recommended at the moment for people who are not symptomatic, because you can carry E4 and, at least get into your 90s, and never show the symptoms. So it's not recommended as a predictive test, but can be, again, used in maybe difficult cases, young onset cases, and so on. So I'm just going to wrap it up by just emphasizing again that the big change is this recognition that Alzheimer's evolves over a very long time. And identifying these early symptoms can be difficult. So you have to have a high index of suspicion. And when I put longitudinal context, it helps to know if somebody's worsening. Normal aging, things change some, but if you see somebody really progressively worsening, that's not normal aging. We are excited about this new criteria that Dr. Cummings will talk about. And I think this payoff for early detection will really occur as some of the disease-modifying therapies are demonstrated to be effective and then become available. And again, I just want to emphasize that we're really fortunate to be able to be involved in the testing of a lot of these agents. And I would encourage you, if you have patients, if you're in the Las Vegas area, you have patients, and they are interested in clinical trials, to encourage them to participate, because that's the only way we're going to learn about these things. So thank you for your attention, and I'll turn it back to Dr. Cummings.